Thank you so much for the warm introduction. I always love speaking with this audience. So as you know, our topic today is recognizing delirium in persons with dementia. And just want to say mahalo to our sponsors. These caregiver workshops are made possible by the Elderly Affairs Division in the City and County of Honolulu through Catholic Charities and Halikawiki, and as well as our Pacific Island Geriatric Education Center at the John A. Burns School of Medicine. So what are we talking about today? Okay, so today we hope to learn how to recognize common features of delirium. We want to know the most common causes of delirium, how to manage delirium behaviors, and how to manage and prevent consequences of delirium. Okay, we'll begin with a little case scenario. So it's Friday afternoon, and Mrs. L's daughter is worried about her mother. She's refusing her meds, saying it's poison. She threw her glass of water and demands to be let out of this prison and threatens to call the police. She has been eating less for a few days and refused breakfast this morning because she wanted to sleep. She has difficulty answering questions. This is not like her. I don't know if you've ever heard of the words sundowning. This is another term to describe what we're seeing here. We'll talk about the key features of delirium in the next several slides. So these are the key features of delirium. This is how the doctors diagnose delirium. It's from the Confusion Assessment Method, or the CAM. And so there's four features that we're looking for. The first feature, feature 1, is acute. Acute meaning sudden onset or fluctuating. That means this is a new behavior in the last 24 to 48 hours. There's a change in their consciousness, their attention or thinking that's sudden. And it fluctuates. It may fluctuate during your interaction. The second feature is inattention. So having difficulty kind of staying attentive. They're very distracted, trouble keeping track of the conversation. You can't follow it, can't follow directions, can't answer questions really easily. And then, so it's feature 1 plus feature 2, and then feature 3 or 4. So the third feature is called psychosis. And what is psychosis? It involves things like hallucinating. So hallucinations are typically things like seeing things that aren't there. And delusions are paranoid beliefs, or believing things that aren't true. Okay, and then disordered thinking is that it's very, very confused, thinking like you're her ex-husband or something like that. Or speech is rambling and going in all different directions. It's unclear, there's no logic, or there's very limited or very little speech going on. And then the other feature is consciousness, or their sleep-wake cycle. So they may be hypervigilant, awake all night, or restless, or the opposite, they may fall asleep while you're talking to them and may be sleeping all day. So if the feature is mostly hypervigilance and restless and awake all night, that's hyperactive delirium. And if you're talking to them and they fall asleep or they're sleeping all day long, that's hypoactive delirium. And actually, people can have both. They may be awake all night and asleep all day, right? So that's mixed delirium. The reason why I point this out is that some people, it's easy to recognize hyperactive delirium, right? Because they're giving you a lot of trouble. It's right here, right? It's very difficult, restless. You can't leave them alone. They could be doing something dangerous, or they're agitating or screaming or doing whatever. Very easy to recognize. But hypoactive delirium is difficult to recognize. There's no trouble at all. They're just sleeping in this morning, or they're just tired from yesterday, right? And they're sleeping all day. But we have to pay attention that does exist as well. Okay, so this confusion assessment method, or the CAM criteria, are typically used when patients present to the emergency department, the hospital, or the nursing, or in the nursing home, and there's a sudden change in condition. the nurses and the doctors do this confusion assessment method to determine whether or not this person has delirium. But what happens if this happens at home, as in our case scenario, right? What are you going to do to help the doctor figure out if they have delirium? Well, you are the eyes and ears, right? You have to provide your observations and your descriptions. So let the doctor know. Do you see any changes in their daily routines? Is there psychosis going on? Seeing or hearing or believing things that aren't true? Is there some crazy talk, disorganized thinking? Can't follow directions, can't focus, having random sleep-wake cycles, and letting them know about whether or not they are physically aggressive, or possible harm to self or others. That sort of helps the provider figure out how severe is this problem and how to best manage this. So let's go back to our case scenario about Mrs. L's daughter and her mother. So let's look at some of the features, right? She's refusing her meds and says it's poison. This is a delusion, right? She's believing something that's not true. She thinks that she's in this prison. She wants to be let out and she threatens to call the police, right? So that is, and she's eating less for a few days and refused breakfast this morning because she wanted to sleep, right? This sleep. So her sleep-wake cycle is getting messed up and she's more somnolent than usual. She has difficulty answering questions, indicating that she can't focus enough to pay attention to what you're actually asking her and formulate, organize enough to formulate a response. So, and then the most important criteria is this is not like her. This is a new change in the last 24 to 48 hours. So yes, she has delirium, right? Now, what about this case scenario number 2? I actually took this case from Dr. Serena Lowe. She's over at Kaiser. She gave a similar talk last month, and she used this case. So I borrowed this from her. This is, I'll translate the medicalese. Like the 98-year-old man, he has a history of high blood pressure, hyperlipidemia, high cholesterol, high blood pressure, pulmonary hypertension, lung disease, osteoarthritis. He's pre-diabetic. He's got AFib or heart arrhythmia. He has heart disease with a heart attack in the recent past, and even had bypass surgery, kidney disease, valve stenosis in his heart, and memory loss that's worsened over the past year. He's very complicated. And he referred this patient to geriatrics, but the daughter was never able to get the patient into the clinic. And she brought him to the emergency room because his behaviors were out of hand, choking her with the walker, reported wanting to kill himself with a butter knife. And then also she noticed he was having hallucinations and delusions, right? So she took him to the emergency room and cleared by psychiatry as not having a psychiatric problem. And they actually did all labs and imaging is all normal, and they had no metabolic or lab abnormalities causing the agitation. So does this guy have psychosis? Let's take a look at those CAM criteria. Is it acute and sudden? Not from what we see here. Like, it seems like this is chronic. It's been going on for a while. It's just been getting more and more out of hand. He doesn't have any notice here about having difficulty with paying attention. He's able to communicate. He definitely has psychosis because of the hallucinations and delusions, but he's not having sleep-wake disturbances or fluctuations that we see here. So I think, we can safely say that this guy does not have delirium. He just has dementia. Very problematic, it sounds like, as well. And they really need to consult psychiatry and work on some behavior modifications and maybe adjust some medicine. So, but this guy does not have delirium. Okay, so what should caregivers look for, right? We need to detect delirium early. So caregivers should look out for early signs. This is called the stop and watch early warning tool that we use a lot in our nursing facilities. And this is acronym, right? The seems different than usual, talks or communicates less, overall needs more help, pain, which is new or worsening, or participated less in activities, ate less, no bowel movement in 3 days, or diarrhea, drank less, having a weight change, agitated or nervous more than usual, tired, weak, confused, or drowsy, or change in skin color or condition, or needing help with walking, transferring, toileting more than usual. So why do we need to determine if somebody has delirium early, right? Because the top 3 causes of delirium are medically reversible problems. They're medical problems. So a lot of drugs, especially a class called anticholinergics, can precipitate delirium. Infection. So if somebody's just started a new drug, like an antidepressant or something like that, then yeah, or maybe they took an allergy medicine or something over the counter, and you start seeing some changes, it could be precipitated by a drug, because it's a top cause of this delirium. Infection. So urinary tract infection, pneumonia, and sepsis, those are the more common ones, but any kinds of infections can push this person over the edge and cause delirium. And then labs, we need to be checking labs, because things like severe anemia or dehydration or low sodium or potassium or glucose being super high or super low, calcium or thyroid abnormalities, these types of lab abnormalities can also present as delirium. And we need to catch this early. So we need to get a medical evaluation right away. This is a medical emergency. Other causes of delirium are things like stroke or heart attack or low oxygen. And if a person has dementia and they're having low oxygen, they're not going to be able to tell you about that, right? Or heart attack or, something like that. They may or may not be able to describe to you that their heart is feeling kind of funny, or they're having a little bit of trouble. Even things like constipation, if they haven't had a bowel movement in 5 days, 7 days, I've seen this present as delirium, and it clears once you treat the constipation, right? Or urinary retention, having difficulty urinating and get the urine out of that bladder. We need to get a medical evaluation right away. And the earlier the better, right? Because otherwise the medical problem continues and can present in a much worse state than if it was found earlier. And what is the treatment? The treatment for delirium is to treat the underlying medical problem, right? Okay, so in the meantime, right, what are you presented with, right? So this lady is presented with refusing to take her medications and throwing a glass of water at her, right? So sometimes delirium presents as an agitated behavior, right? And so the approach here is tada, right? Which is tolerate, anticipate, and don't agitate. So if it's not dangerous, you can allow the patients to respond to their environment and observe them. And you might get clues as to what is upsetting them. They're throwing their glass of water. You can inquire a little bit about them. Oh, what's going on? You're not feeling well today. Okay, tell me about it. So just follow them, tolerate it, and see where this leads. That you might find out more clues. They might tell you that, oh yeah, my belly hurts, and then you'll notice that maybe they have a urine infection or something. Anticipate. Behaviors are a way of communicating. And if they cannot tell you, we need to try to think ahead to meet their needs and to avoid frustration and danger. Okay, and don't agitate. If they cannot reason or understand, don't try. Sometimes even reorienting them can make them mad. So go with their flow, try distraction or humoring them, right? This is hopefully a temporary condition. And so we're just going to go with the flow and hopefully get to some level of cooperation, right? How do we get to cooperation? Well, the problem is when your brain is in a delirious state, it's a little out of whack, life looks very, very confusing, and it's scary. The patient has an urgent need to feel safe. We need to be aware of our body language. We need to speak slowly and calmly and show empathy and respect and address their feelings, which is they're scared, right? Apologize and agree with them. Just nod your head, agree. Everything they say is they're just trying their best to communicate how they're perceiving the world, and then back off and try again later. They're refusing the meds now. You know what? Try again in 15 minutes or half an hour. It's okay. Show concern. I noticed that you did not eat breakfast this morning. That worries me. Can I do anything to help you feel more comfortable? Or just listen to them. Don't dismiss them, right? Take them seriously. They can trust you, right? And then, of course, personalized care. Don't do to them, do with them. So if they're refusing, use their favorite drink or food or person or music or whatever it is. So if they won't take their meds, but they like ice cream, well, let's pair it, right? Ask for permission. Don't demand them to do stuff for you. Redirection. Consider music therapy. Music does wonders for a lot of people. It's very soothing. And also gentle sensory stimulation can help people get to cooperation. And what about medicines to manage delirium and psychosis, right? I think many of you have heard that there are medicines like, I wrote the classes of medicines here on the left and the specific ones on the right. So benzodiazepines like Aida Wen, right? Well, people like to use it because the person falls asleep. It's basically a tranquilizer and they fall asleep. It doesn't actually take care of the delirium. It doesn't do anything to cure them or help them. It just puts them to sleep. But the problem with benzodiazepines like Aida Wen and that class of medicines is that it can cause rebound agitation. So they're sleeping, and then when they wake up, they're more agitated than they were before, right? And so you don't want to get into that cycle. And Aida Wen can also result in disinhibition. So things like they're not inhibited to do crazy things or say crazy things. So that's the problem with benzodiazepines, and they're just very sedating. Antipsychotics are often used to manage psychosis. Things like Haldol, Seroquel, Risperidol. You may have heard of some of these drugs, and what this does, it kind of blocks a chemical neurotransmitter in the brain called dopamine, and that can help manage some of these psychosis and confusion in the brain. There's antidepressants. These serotonin reuptake inhibitors are in a class of antidepressants like Celexa and Lexapro. And sometimes these are used to help manage the delirium as well. And then there's anti-seizure medicines because it kind of calms all the nerves down everywhere in your body. It settles all the nerves down. They're not firing off like crazy, including in the brain. And so it helps settle the mood down a little bit. So these are the different types of medicines that people use, psychiatrists use to manage some of these difficult behaviors. Problem is there's no free ride, right? There are lots of side effects associated with it. So some common antipsychotic side effects that we need to look out for: something called metabolic syndrome, which we see in people on antipsychotics for a long time. So what happens? You might see the development of diabetes. Your sugars are a little bit out of control. High blood pressure, cholesterol starts climbing, and people start gaining weight, right? And there's a black box warning in the package insert for these medications that include things like heart attack, stroke, and death. So we really don't want to be giving these drugs long-term if we can help it. Another antipsychotic side effect that happens if used longer term are movement disorders. Fancy words for this, extrapyramidal symptoms, that's EPS. And so folks, because we're blocking dopamine, we're sort of mimicking Parkinson's disease. And so they may have some tremors, some shuffling gait, slow movements, or we may see kind of a paradoxical akaesthesia, which is restlessness. And so they're just kind of fidgety overall and just getting antsy. Dystonia is an involuntary painful muscle contracture that's very like when you sleep on the wrong side, you get a crook in your neck, except it's really, really painful. Your neck is twisted and kind of stuck like that. That's dystonia. And another one is tardive dyskinesia that may develop over time, which is you may see, rapid blinking, squirming, twisting, or the tongue thrusting, num, 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 like that, or twisting, and arm movements and legs are just crossing and uncrossing and, up and down and all things like that, changing positions all the time. So this type of restlessness and twisting and squirming and abnormal, involuntary movements, they're not trying to do this. So to medicate or not, I would say that antipsychotics and sedatives are only to be used as a last resort. If the patient is very distressed or in danger of hurting themselves or others, then we consider medications for the short term, not long term, short term. If the behaviors are dangerous, and sometimes they are, then we need to get help. However, you should know that there are very few or actually no geriatric psychiatry hospital beds in the state of Hawaii. And if they get admitted to the hospital, it may only be for the medical workup. So they're going to figure out, you know what, they got delirious because their sodium is low, or they have a urinary infection or something like that. So they're going to do the workup. And hospitalization or medications may not solve the problem. And ultimately, a change in the approach is still the most effective intervention. So what does this mean? It means that most likely, mom and dad will be going home with you again to continue treatment of the underlying problem. And then you will be left to handle the delirium until they are, quote unquote, better. And that's probably what you need to be prepared for. So it should be no surprise, but no one tells you this. But, when your brain is compromised, you need more help with care. And there are a lot of unintended complications. So families and caregivers should know that they should expect to provide 24/7 care until the delirium is cleared. And this may take weeks or months even. So for example, if you have delirium, you may not get clued in that you have to go to the bathroom and you wind up with incontinence. Never incontinence before. Usually before was able to go to the bathroom and everything was fine, but now all of a sudden they have urinary incontinence, right? Because they're not picking up on the cue or being able to get to the toilet in time. So what do we do with that? We need to be aware of their toileting schedule and start a toileting program. So, okay, it's kind of like your toddler, right? Take them to the toilet every 2 hours to prevent them from having urinary incontinence. Immobility and falls, right? If your brain is not working quite right, then it's going to have poor judgment, poor safety awareness, more unsteadiness. And so oftentimes, and this happens often as people present with delirium with a fall, right? Or a fracture, something like that. So in order to prevent future falls, we need to just basically, follow them everywhere, right? Mobilize with assistance and maybe even consider physical therapy, right? Because they're not safe walking around, and falls are very, very common because of their either weakness or poor safety awareness from the delirium. And pressure ulcers can also happen, especially if patients have hypoactive delirium. Hypoactive delirium is very easy to manage because you don't actually have to do anything. They just stay in bed and they sleep all day. But if they sleep all day and they're not moving and repositioning, they can develop pressure ulcers, especially if they're really thin and they don't have a lot of padding. Then that can be, and then it's going to take months and months to heal pressure ulcers. So it's better to prevent those and just be aware of a need to reposition. Even if they're in a chair, right? The chair should have a cushion, or in the bed, reposition with pillows, extra pillows in the bed from side to side to make sure that they don't develop these pressure areas. Okay, and what about sleep? Yeah, so they may have sleep issues. So instead of, so if they're, you know, up, sometimes you're like, let me see, it's 2 in the morning. I need to sleep, right? So you give them a sedative and then they sleep, but they actually don't wake up until 2 in the afternoon, right? Then you kind of contribute to the problem, because then they'll be awake at night and then you kind of go round and round. So if we can avoid sedatives as much as possible, or we can um, time them to kind of coincide with the normal schedule, then that might help. But sleep protocol, maybe making sure that we have a quiet environment, pull the shades, have it dark at certain hours, things like that. And this is a very common one: poor nutrition and hydration or aspiration. So sometimes when folks have delirium, they don't remember to eat. They're not. So they may you put the food in front of them. Well, they may not actually eat it. You might have to cue them and say, hey, take a bite. Hey, chew, swallow. You may need to assist with feeding or provide cueing, and then aspiration precautions, because they may not chew completely and try to swallow, or, eat too quickly, or, or pocket foods in their, I've seen folks pocketing foods and liquids in their cheeks. They forgot to chew, and then they take the next bite, and then they take the next bite, and they're stuffing their mouth, and then they aspirate, and food goes into the lungs and they get pneumonia. So yeah, so there's a lot of complications with poor nutrition, dehydration, or aspiration, because they need cueing and regulation from caregivers to help them navigate this part. And then hopefully, right, they're getting their antibiotic or their potassium supplements, or whatever it is that they need to treat the underlying condition. And as they begin to recover, you actually need to adapt to their abilities to enhance or maximize recovery. So for example, as their brain is clearing a little bit, right, you might want to, help reorient them a little bit to time and place and person several times a day. Now, I know I mentioned earlier that sometimes that can cause agitation, and people can get irritated because you keep telling them, where they are and reorienting them. So if it's irritating them, don't do it. But if it's helpful, that can help them kind of get their bearings. Okay. The other common thing that I see is depression, right? Sometimes when people have a setback, like a fall or a fracture from their delirium, or infection, or some stroke or whatever, depression will set in. They're going to get discouraged. This is not, they're kind of stuck in their bed. They're not able to do stuff or walk around independently. Depression will set in, and depression will limit their progress. And so, try to kind of preempt this a little bit and try to implement scheduled pleasurable events. So this is something we call behavioral activation. So whatever is realistic that they can do, something that they enjoy, maybe, make sure you have, the granddaughter from California, calling in and checking on grandma, or, something, right? Schedule in pleasurable events to sort of preempt this thing before it really gets bad. And just monitor for depression. Next is the ability to perform activities of daily living, or instrumental activities of daily living. These are things that allow them to function at home, right? So family education. So as delirium reverses, the family can adapt to allow greater functioning matched to ability. Sometimes we say, oh, they can't do it anymore, and then they just do everything for them and they don't do anything anymore. Right? They just passively receiving, and they kind of forgot how to, brush their teeth, or feed themselves, or get dressed, or, transfer and walk. So they may need cues, but allow them to do more and more as you see them improving. Some people get stuck and becoming quote unquote institutionalized, right? Or becoming dependent, because we kind of promote or facilitate that. So we need to, this takes a bit of finesse, because you don't want to make them feel frustrated that they aren't able to do certain things, but you need to be able to foster whatever they can do. So that's important to pay attention to. And then finally, I just want to say that sometimes, so oftentimes delirium, if you treat the underlying cause, most people, their condition will reverse. The delirium will reverse. And usually within a week, they'll be back to normal. I've seen folks take 2 or 3 weeks. I've seen folks take 2 or 3 months. And I've also seen folks never recover, right? Sometimes it's that bad, but hopefully you're in the percentage where you're recovering within a week or a couple of weeks. So I think it's important for families to know that delirium may persist, no guarantee for recovery, and the family may need to consider long-term support for functioning, such as, feeding, bathing, toileting, and taking care of their finances or their medicines or housekeeping or whatever it is they need to stay independent. So ADL support may be required for a long haul, and it's probably good to just think about it and have things lined up in case, but you may not need to use it. So, okay. And then, so in summary, I want to emphasize that early recognition of delirium is important, right? The earlier we catch an infection, the easier it is to treat, and they don't get as sick or as severe, right? Early recognition of delirium is important. This is a medical emergency. The most common causes of delirium are medications, infections, and chemical imbalance. So when you talk to a doctor, think about those things going on. What happened recently? Was there a recent change? There's something going on that's different, right? So paying attention to that. And a calm, reassuring approach is the best approach, because we really don't want to use psychotropic medications if we can help it at all, right? You don't medicate your toddlers or your babies when they're crying and screaming and carrying on, right? You work with them, you talk with them, you calm them down, right? You listen, try to gain some cooperation, right? And you can also help manage and prevent potential complications of delirium, as we discussed: prevention of urinary incontinence and pressure ulcers and dehydration, malnutrition, function, all those kinds of things. So I hope this was helpful for you. And I'm gonna open it up for a lot of time. I suspect we have lots of things we want to discuss and questions that may come up. So thank you very much.